Welcome to the Moulding Health Show. Our goal is to leverage the wisdom and experience of healthcare practitioners to set you on a path of self-discovery and healing. These insights, coupled with a multidisciplinary approach to each area of interest, should provide an invaluable resource to everyone looking for a better approach to health. In this episode of the show, we speak to Johanna Matsetela about substance abuse from the perspective of an occupational therapist. Johanna Matsetela, welcome to the show. We're really glad to have you on board. Thanks so much for doing this.
Thank you for inviting me to the show. It's an honor.
No, I mean, the honor is always ours, and we get to meet amazing people like yourself, Johanna. And so we're talking about substance abuse from an occupational therapist perspective. And I would have never put those two, like that discipline with substance abuse. And that's why I say, the pleasure is always ours because we get to speak to amazing people like yourself. But before we get into the topic, I'm always curious in terms of how you actually got invited. I don't do the invitations always. It's always curious for me. But how did you get invited to the show, and what prompted you to be part of it?
Well, I've been getting emails for me to present on certain topics of occupational therapy. However, I've just been very occupied. So there was this one time she has sent me an email requesting me to do a presentation on substance abuse. And I thought that's a very topic of interest. So I would really like to share my thoughts on it and just what I do on a daily basis regarding substance abuse.
I know, that's amazing. I think it's such a, before I give you my thoughts on it, in terms of other people we've invited onto other shows as well, where we talked about it. But if I just talk, it sounds like it should be obvious, but tell us, what is substance abuse?
Yeah, it sounds quite obvious, but it actually isn't. So before I actually define what substance abuse is, I would like to introduce a term, substance use disorders, which is used in the field of mental health instead of substance abuse. Now, this has been used since the publication of the 5th edition of the DSM-5. Now, the DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders. So it's been commonly known to describe an individual who regularly uses substances or drugs as a substance abuser, an addict, or an alcoholic. However, research has discovered that all these words can be negative and stigmatizing. So that's preventing individuals from seeking help and receiving care without prejudice. So for a long time now, mental health professionals have long argued that labeling an individual as a substance abuser is defining a whole person by their condition. However, when an individual is said to have a substance use disorder, it is understood that they have a medical problem, and that does not define the entire person. So going into the definition of substance use disorder, because that will be the term I'll be using throughout the presentation or the interview. So according to the DSM-5 that I mentioned, substance use disorder is a problematic pattern of using substances that often results in impairment in daily life. So these patterns of substance use may cause problems with health, they may cause problems with relationship, work, or school. So in a nutshell, substance use disorder can also lead to risky behaviors, legal problems, physical harm, or even death. So from an occupational perspective, in a nutshell, substance use disorder presents a dysfunction in occupations.
Okay, so is that how the occupational therapist part comes into it? It's because it.
Yeah.
Okay, that makes sense.
Yeah, definitely. Yeah. But then I think the other thing is that what kind of substances are we talking about here? Because it's just a general term. So we do have clusters of substances that people can use compulsively. So oftentimes you would get clusters like depressants. So your depressants are your sleep-inducing substances, for instance, alcohol or sleeping tablets. And then you get your stimulants, which increases alertness, for example, nicotine, cocaine, crystal meth. Then you get what we call your hallucinogens, which changes or alters perception, For example, your LSD or your ecstasy, known as the party drug or the MDMA. Then you also get what we call opioids, which are pain-relieving substances. For instance, the common ones, morphine, codeine, and heroin. And then you get other substances that can't be classified because of their varied effects on the body. For example, cannabis, and then you have your inhalants as well. So those are the substances that are often culprits of compulsive use. So oftentimes, because substance use disorder is now regarded as a chronically relapsing mental condition, there is a criteria or signs that are used in order to diagnose substance use disorders. So these criteria you would find in the DSM-5 that I mentioned previously, what is commonly known as the Bible of psychiatry. So a lot of people who work in mental health would understand what I'm talking about. Mm-hmm. So yeah, but before I go into the signs or the criterias of substance use disorders, I think it's important that I highlight the progression of substance use that is often seen in these individuals. So oftentimes people would use substances for recreational use. So often that's how it starts. So now this is where a person is curious about a drug, maybe because others are using them or they've asked them to use. And it usually happens in a social setting, like at a club or a family gathering and so forth. So the substance can be consumed in small to moderate amounts. However, accidents can happen. So you might get intoxication and you might actually get overdose as well. So and then it progresses to what we call occasional use. Now, this is where an individual uses the substance for a specific reason. For example, maybe to relax or maybe to feel confident as well. Then it progresses again to regular use. Now, this is where a person now starts using the substance daily or almost daily in either small or to moderate use to deal with certain problems or to maintain some level of performance at work or to help them with anxiety. So now, oftentimes at this stage, that's when we start seeing problems related to substances surfacing. And then the last stage is compulsive use, which is what we are really concerned with, because this is a stage where there is continuous use of substances daily or almost daily, and the substance take precedency in the person's life. So if we were to put it on a pyramid, it will be at the top. So the person is preoccupied with using the substance, getting the substance and recovering from it. And then that's when we get to a stage where we say they have substance use disorders.
Okay. And if I had to just go into it, Johanna, but because I know we're going to come to it now, but so how would an occupational therapist normally help with that?
So looking at the criteria of substance use disorders, I think because we have 11 of them, and depending on the number of criteria that you have, an individual can have mild, moderate, or severe use of substances. So when I look at the 11 criteria according to the DSM-5s, I'm not going to go into more details into them, just going to highlight a few. For example, when can you tell when an individual has a substance use disorder? So they will experience cravings to use the substance. They will be unable to reduce the quantity or stop in spite of trying. They will need more of the substance to experience the same level of intoxication. They will use more quantity of the substance or for a longer period intended. They'll spend a lot of time on substance-related activities, that is getting, using, and recovering from the substance. There is reduced involvement or time spent on social, recreational, or work-related activities. And I think that criteria is the one that us as OTs are really concerned with. I'll come back to it. And then the other one would be using the substance in spite of the impact on physical or mental health. They're unable to carry out responsibilities expected at work, at home, and in other situations. And that's another criteria that we look at as occupational therapists. They use the substances in situations that may be physically dangerous. Oftentimes, you'd find that they experience withdrawal symptoms when they stop using the substances. And usually these withdrawal symptoms are negative, either physiological or mental symptoms that can affect them badly. And then the last one would be having problems with relationship due to substance use, but they persist using the substance. So of the 11 criterias, if a person meets 2 to 3 criterias, they're in the mild. If they have 4 to 5, they're in the moderate. And then if they have 6 and more, then they have what we call severe substance use disorders. So now, where do we fit in as occupational therapists in the treatment of substance use disorders? So oftentimes, when you see a client presenting with SUD, the first thing you would want to do is do an assessment as an occupational therapist to evaluate the extent of impairment in occupation due to substances. Now, this can be done by having an interview with a client to find out about their occupational history, their patterns, what they used to enjoy doing, what kind of occupations have been affected that they would like to go back to. And then another role that we assume would be that of implementing treatment. Now that is facilitating engagement in previously valued or enjoyed occupations, because with substance abuse, like I mentioned, there's preoccupation with the substance. So all these other occupations that an individual used to enjoy and love doing somehow falls at the back. So we would help discover new routines and habits that will bring about fulfillment and improve quality of life. And then another role would assume is that of an educator. So now that would be to facilitate understanding about the condition to the client and the family members through psychoeducation. So that will be just explaining to the family what the condition is, what their role is, how can they assist, and so forth. And then also to discuss and identify the negative effects of substance pattern in a client's life. So another role as well would be that of advocacy. So now that will be to advocate for comprehensive substance use disorder programs or influence policies or legislature to prevent and reduce substance use disorders. And then oftentimes, because substance use is a chronically relapsing condition, we do expect clients to relapse at some point. So once they do relapse, we then come in to reevaluate as well, looking at the behavior patterns that may have been involved in the person relapsing. So now that will be building on new behavior patterns and assisting the service user, that's what we call them instead of addicts, the service user to fill the void with activities which are most likely to produce a feeling of happiness and fulfillment.
I've never heard that term before, by the way, service user.
So oftentimes, clients would be called addicts, alcoholics. So with the new research that has come up, it was discovered that it is better to call them service users as opposed to the negative words that have, like addiction, that have a negative connotation to it.
Okay, cool. We actually had someone, and he's got a center on the East Rand, where they, like where they do rehabilitation and stuff like that, and it's called ARC, and he was talking about addiction, and but this term is like so, like the whole addiction or drug addiction is so prevalent in society. So I suppose, it's going to take a lot of work to almost reverse that and, start using new terms, I suppose. But I think it's a step in the right direction. Very cool.
Yeah, definitely. Because oftentimes individuals with substance use disorders refrain from seeking help because of stigma. So in introducing new terms, we're trying to bridge that gap to say, this is a medical condition, this is a brain disorder, so it should be given the same attention as other medical conditions like diabetes or hypertension. So yeah, so we're trying to get clients to open up and come for treatment without prejudice.
No, no. I mean, I think anything that helps, obviously, is would be very welcome because we're dealing with serious consequences for people. I mean, serious consequences for families, for for the community, for everyone, basically. I always find it interesting, because I've worked in quite a few plants, more on the project side. But whenever you go into these plants, I mean, like they always have like breathalyzers, and you have to check. But what you said earlier, I was thinking about, because the whole like withdrawal symptoms and the whole like efficiency at work. The person might not be intoxicated, but as you said, like they're constantly thinking about it. Obviously, that is going to affect their work. Have you found, I mean, from an occupation point of view, have you found that there's a lot of that part in terms of people not being able to do work because of that?
Yeah, definitely. It's quite prevalent actually. And I think that's where as OTs we play an important role, because one of the occupations that we focus on is work. So oftentimes clients that would see sometimes would be referred by the employer, complaining of poor job performance, absenteeism, the conduct at work. So it's quite prevalent. Unfortunately, it's only, oftentimes it is only discovered at a severe stage where an individual now requires an inpatient treatment, as opposed to one having a mild substance use disorder, and they can have an outpatient program for going for themselves. So yeah, it's quite prevalent. Most of the clients that I see, this is so common, and the employer oftentimes has had enough, unfortunately. But I think, like you mentioned as well, that we still have a long way to go regarding substance use disorders, because oftentimes it is regarded as a self-inflicted condition. You're the one who went to drink the alcohol, and oftentimes is associated with lack of morals or not having control of your life. But unfortunately, yes, sometimes it does start as a choice. However, with progression and the quantity of use and the duration of use, an individual can end up having a substance use disorder, which we now treat as a mental health condition.
I can see that. Hey, I mean, there's definitely dotted lines there. I mean, you touched on so many interesting points, which is like, it's taboo in society and stuff like that. And if I touch on the like almost like the mental health aspects of that, I mean, the person obviously can't be feeling good, especially if they're at that stage where they're so dependent on the substance. And I mean, it's not like I think they can't see the effects that's happening in their jobs and stuff like that. So yeah, interesting, around the mental health part. I think we had, not on this show, but on another show, we had an author, and her name is Tando Pato, and she actually wrote a whole book, around her journey of, overcoming substance abuse, which I thought was amazing, because she was like high functioning, everything, but you could, even, what she was saying, and even in a book, she says that it actually affected her life, it affected her career, it affected, relationships, and it was just, and when she put almost like the peg in the ground and said, actually, I want to stop now, that was the difference.
Yeah, and oftentimes that's what we don't see in
Mhm.
the field of substance use disorders, because in most cases, the clients that we get are either forced to go for treatment because they want to preserve their jobs, or they've been given an ultimatum that if you don't go to rehab, then we are going to abandon you, or we're going to disown you. So it's oftentimes it's not intrinsically motivated. And yeah, so once you get a client who has intrinsic motivation and they have a reason for change, I feel personally that you're looking at a person with good prognosis as opposed to somebody who is not yet at the stage where they would like to change and they have now seen that the substance has affected their lives in the worst possible manner.
Yeah, I think that's I mean so true. I mean, I suppose you can't force people, like to do something if they don't want to do it. I think that's the key thing, and it always starts with your own mind and your own beliefs and drive and all of that stuff. I want to tell you this though. So we've got two children, and our older one, um, when she was younger, we used to use this teething powder, and it was called Vidal. And and she, I mean, like it was amazing because every time she had like teething issues, just put Vidal. And for our second child, we were looking for the same thing. Obviously, when he started teething, and it was off the market. Like, and I asked the pharmacist one day, so why is that? Because it was like amazing. And she was just saying, people started using Vidal, like from a substance abuse perspective. And I thought that was so interesting. And it's for me that what it highlighted was you always think of the major things, like alcohol and this and that. But what you highlighted for us already is like how you break down even what substance abuse is, which is like so interesting.
Yeah.
Yeah.
Yeah, it's quite interesting because, and oftentimes substance, when you say somebody has substance use disorder, people are thinking, oh, he's using cocaine, he's using heroin.
Mm,
Yeah, it can also involve things like being addicted to pain medication, for instance, you
yeah.
know, yeah, or just it's not only about the illegal substances, but legal are also culprit in this instance. Your alcohol, your nicotine, your caffeine.
Mm.
Um, I was talking to my colleague this other day, and I know she can't go a day without a cup of coffee. So we were having this discussion, and she was just saying, am I am I heading towards the direction of being addicted to coffee? Because my goodness, I can't go a day without coffee. And when I stop using coffee, I experience some negative symptoms. So it's quite interesting. And like I highlighted, you can have someone who has a mild substance use disorder, a moderate, or a severe. The only part we are concerned about is when it affects an individual's ability to function in society or to participate in occupations that are valued in their lives. So I think once it gets to that stage, then we need to intervene. Even
Mm.
even at the initial stage, you can do things like brief interventions for those that are still experimenting with substances in order to prevent future admissions, or future addiction. So as people would refer to, or substance use disorder.
Mm.
So yeah, so we also do prevention as well, where we do awareness. We go to schools, we go to workplaces, present on substance abuse, what are the signs, and what interventions are there for those that feel that they're heading towards the root of substance use disorders.
Mm.
So yeah, so I believe prevention is better than cure. So a lot of times we really prioritize prevention as well.
Yeah. So when I was doing the research for the show, I mean, the one that came up very strongly was prevention and rehabilitation, of substance abuse. So I think you covered the prevention part. From the rehabilitation part, is there anything that kind of springs to mind?
Yeah, so in terms of rehabilitation, like I mentioned, um, people become addicted to substances, to different substances, right? So I'm not going to go too much into the medical part of how addiction comes about, but oftentimes we find that these substances that have been taken, somewhat changes the structure of the brain and some of the functions of the brain, especially the reward system of our brains, where it controls also our control impulses are important in this instance. So oftentimes you find that when people come for rehabilitation, they do display some sort of cognitive impairments as well. So with regards to occupational therapy as well, we tap into that to say, fine, we can see that this individual has cognitive impairment. So how can we best assist them to be able to perform adequately in occupations? So for example, during rehabilitation, we have seen that a lot of people, there's obvious self-neglect, which is part of your basic activities of daily living. And these are activities that are directed towards looking after yourself. So we would try to come up with simplifying task sequence to try and help the service user with cognitive impairment to complete, for instance, like a morning self-care routine. So I know it sounds like a very simple thing to say, but how can you try and teach somebody how to look after themselves? So oftentimes with substances, that is the number one intervention that we do as part of rehabilitation. So the nice thing about the field of substance use disorder is that it requires a multidisciplinary team.
Yeah.
So you would have your psychologist as well, who will address psychological factors that may have played a role in the person's addiction. And then occupational therapists obviously will look into functionality and engagement in occupations. Then you also have your medical team who assist in detoxification, that is the elimination of the substance from the user's body so that they can undergo rehabilitation with a sober mind, so to say. Yeah, and then we do have psychiatrists as well, because oftentimes after detoxification, service users that shows symptoms of mental health. And you also might find that an individual with substance use disorder had a mental health prior to the use of substances, which predisposed them to developing substance use disorder. So really it requires a holistic approach to try and get the individual to be able to return to normality, if that's a thing. yeah, to return to normality. But oftentimes, because like I mentioned, we know it is a chronically relapsing condition. So we can't necessarily say after rehab or after someone has been admitted for 3 months or 6 months, after that, they're going to go back to normal and they'll never, ever use substances in their lives. Yeah, definitely that's the reality of substances. Chances of relapse are always there. Can be 10 years later, can be 20 years later, depending on the triggers that the individual comes across.
That's such a sad point, eh? I mean, and you pretty much articulate what I always thought about. Like, I used to always joke, when I used to work with colleagues and the smokers, because I always said, there was this friend of mine. He's actually a business, like he's a business partner now. But I remember this time he wanted to give up smoking, and so we took a bet. We were in the USA at that time, and we took a bet, and he's like, okay, cool, and he came up with some ridiculous amount. I think it was like a PlayStation game or something. And he says, I'm going to give up like smoking, and if I don't, then I'm going to buy you a PlayStation game, which was quite expensive at that time, I think. I think it still is now. And I was like, okay, cool, no problem. And within 2 days, he comes to me and he's begging, to extend the time. And I was like, yeah, sure, no, no problem at all. Because for me, it was like such a secure bet. I mean, like it didn't matter whether it was like 2 days or 1 week, and true to form. I mean, I think he lasted probably like 4 weeks or maybe 3 weeks, and then I got my PlayStation game. But but it was this thing about, smokers. I have the same belief. But, on a serious note, I mean, I think what you said is really important, which is you need to almost control the triggers, because I think, like with smokers as an example, I mean, if you mix alcohol and then smoking seems to come straight after that, on that evening. So I think it's the same thing. You just have to get rid of the triggers, or try to minimize it, maybe. To
And during the process of rehabilitation, that's also some of the things that we focus on, looking at triggers, coming up with new ways of coping, teaching them new coping skills, so that they can be able to deal with triggers once they arise. So that also forms part of treatment, because oftentimes, if you know what your triggers are and you learned to somehow compensate for that, the likelihood of not returning to substances are high, as opposed to, not knowing what your triggers are, then you don't necessarily know how to avoid not having to use the substance.
yeah. And
Mm.
Joanna, I know when you were talking about, I love the fact that you mentioned the multidisciplinary team. It's something I always like to ask about, so that anyone knows, like if I'm going down this route, I probably need to speak to multiple people. I didn't see you mention a dietitian. Does a dietitian normally fit in there? Because I mean, typically people with substance abuse, I mean, they obviously their health is not great. Do you find that that comes up at all?
Yeah, definitely. We do liaise with dietitians as well, especially in an inpatient treatment center, because oftentimes service users demonstrate issues with feeding as well and eating, because they've spent so much time preoccupied with the substances. Their diet somewhat just fell off, and also their bodies are now not able to tolerate the intake of food, solids, and so forth. So oftentimes you'd find that in terms of, like menu alterations, menu ideas, um, rehabilitation centers or treatment centers do consult with dietitians, but it's unlikely that you would find one stationed permanently at a rehabilitation center, but they do form part of the multidisciplinary team.
Mm. Yeah, thanks for saying that, because I always wondered, but you're completely right. I mean, and we did have an interview with a few dietitians so far on the show, and I think the one was based at like a psychiatric day clinic or day hospital. But I wonder, yeah, I should actually ask the founder of ARC again, if they have a dietitian on their list, or on their team, because that's quite an interesting one. I would think
Mhm.
that there's definitely a need for it, but again, I don't know too much about it. I'm learning all the time.
No, definitely. No, you're right. Especially because, substance use disorder is such a comprehensive disorder. It requires everyone to come on board, more especially because it affects an individual's brain, it affects the physiology of an individual's body. So now you can imagine all the body structures, all the cognitive abilities. Somehow, this person requires all the necessary intervention from all the multidisciplinary team as possible, physios included as well, because they do also, you do also get that there's poor physical endurance as well after detoxification. You have general body weaknesses. So it's quite a complex condition to treat.
Yeah, yeah. I mean, you always forget some practitioner, but but I mean, I've got a lot of respect for OTs, in terms of learning. 9 years ago, I didn't know what an OT does, and based on
Yeah,
what,
yeah.
yeah, and based on what we do now, I mean, I've got so much of respect for OTs, and also with our children, in the earlier years, looking at OT stuff. The whole sensory integration wasn't part of my vocabulary, but now it is.
Right.
Um, but definitely dietitians. I think dietitians are so, in many ways, underrated. Like in terms of how important that stuff is. But it's like,
Hmm.
if we don't get our like body chemistry right and like eating right, I mean, there's so many other knock-on effects, and it just starts with like eating and eating well and just drinking water every single day, and
Yeah, definitely, definitely. Yeah, the patterns, and oftentimes that's also what we look into as OTs, occupational pattern history, how have you been using your time before using substances? Because oftentimes when you look at that and you sit down with a client and you try to just table how they used to spend their time, you'll be shocked.
mm, mm,
And yeah, so that often gives room for doing things that are not in line with what you like, what your roles are and responsibilities are. And then they end up occupying the time with the use of substances. So yeah, so you're right, just the basic simple routine, waking up in the morning, getting out of bed, making your bed, you
mm,
know, having a glass of water, eating right, eating healthy. Yeah,
mm.
so yeah, you are right. Dietitians are actually underrated in this field.
Yeah, I'm sure all the dietitians are clapping at the moment, but yeah, I firmly believe in that stuff. Um, and Joanna, I mean, you've seen so many clients now. I mean, and through your private practice and obviously as you became an OT, is there anything that you would say to someone that around avoiding substance abuse? I mean, is there something around that you would say, what I've seen with many clients is that if you did this, you probably have a better chance of like avoiding being one of those service users.
Yeah, I think with that, would have to first look at why do people use substances in the first place. Because once you understand that, then you can come up with ways in which you can help try and prevent that. So oftentimes, people use substances, or some of the factors that plays role into the development of substance use would involve environment, where a person lives, the availability of drugs, the attitude towards drugs, peer pressure as well, issues
Mm-hmm.
with family, neglect as a child, issues of poverty and so forth, and the kind of lifestyle that an individual lives, the patterns of engaging in occupations like I mentioned. So oftentimes what I would advise clients, or what we usually work on with clients, would be um, to work on your occupational history, try and improving your engagement in occupations. For example, a basic routine, a 24-hour routine of how you occupy your time constructively. So not just watching TV the whole day and then you're bored and now you think of something else. So I would advise, just working on a constructive occupational patterns, that's going to give you fulfillment and contentment, because oftentimes individuals who resort to substance use disorder oftentimes feel lonely, they feel lonely, they feel sad, they feel bored. So, and some don't even know what they like. So we also help them to discover the things that they may enjoy, and just to utilize that in order to create a meaningful life in the individual's life. And
Mm,
then oftentimes this issue of genetic makeup that people tend to underestimate.
mm,
You oftentimes you don't know whether you have a mental health gene lying dormant somewhere in your body.
mm, mm,
So yeah, and that's where we get what we call substance-induced psychosis. You don't know whether you in the family there's history of mental health, then you just experiment with substances with your peers. Cannabis is a culprit in this instant. You experiment with cannabis and you experience psychosis. You start seeing things, you start hearing things, and the next thing you know, you're admitted at a hospital. So I would advise, especially with this happens a lot with teenagers. So yeah, just regular engagement in occupations, prioritizing social participation, finding healthier ways to induce endorphins, go to gym, socialize with friends, even in the absence of substances, going for a picnic, going for hikes, all these activities, but to some extent, they should give you meaning, because when you do something that you're not obligated to do, that's when you experience good quality of life,
Mm. Yeah, I mean, it touches on all of these, like again, it's the simpler things, it's like doing life better. But it's the things that we forget how to do. And I think, maybe it's generational as well now and stuff like that. But I think the other important point, and again, this is might just be my movie version of it, is that people, like, it affects different people in different ways. The same like with alcohol, and you don't really know what those limits are. And I think when people are testing those boundaries, you mentioned cannabis and psychosis and stuff like that, but you don't know what that is. You don't know if it's like one joint or is it two joints or and I think when people start pushing those boundaries, I think that's where the overdosing kind of comes in. I'm assuming, and things like that, is because you don't know what those boundaries are, because you're dealing with really uncontrolled situation.
Yeah, definitely. And I think the other important aspect is that not everybody's ultimate goal is sobriety, especially with our clients who use substances. Some would want to find ways in which they can still use substances but be functional. Hence, research has introduced something what we call harm reduction, So for those, so harm reduction is just for those clients who are not yet ready to stop using substances, but then, however, they still want to be functional in life. So that can also be a treatment modality. And oftentimes you would find that I'm sure you've heard of harm reduction as well, whereby, substance users or substance service users who inject themselves are given clean needles, just to try and prevent more harm of transmitting other conditions, other medical conditions or chronic conditions like HIV and so forth, or learning ways of taking the substance in adequate quantity so that you don't develop tolerance and so forth, So those are some of the things that we look into with individuals who now see that they're heading towards a severe state of substance use disorders, and they'll just like to somewhat remain in the middle, or just while they're still moving through the stages of change. So we also just try and keep it at a level where it's not compulsive.
Yeah, I must admit, I mean, and in all honesty, I've never come across that term before. So I've learned two new terms, which I find absolutely amazing, which is harm reduction now. And then the other one was service user. I mean, it's in my vocabulary now. But yeah, it does make sense. Coming back to the smoking one, I've seen at least two instances where, despite, like what the reservations I had, and at least two people proved me wrong when they almost like went cold turkey. They just decided that the next day they're going to stop smoking, whereas normally with smokers, they wean themselves off, like I used to have 2 packets a day. Now I have 1 packet and then going down to 1 cigarette maybe. But both of them, and then they kept clean with it. And I thought that was interesting, how they do that. But I never came across the term harm reduction, which is interesting.
Some people do actually do rehabilitation on themselves without even being aware of it, and harm reduction is actually a more safer way of doing it, as opposed to just seizing the substance completely, because one can experience withdrawal symptoms and they're often not nice, then you just want the substance again to alleviate the symptoms, you know.
Mm.
So yeah, so but if you just reduce it gradually, then the body also adjusts to that. Then eventually you get to a stage where you don't want it anymore.
Okay, cool.
Mm.
I'm coming full circle from where we started, when you were talking about work and, normally you get called in from the employer saying, this person needs some serious help or else, they obviously can't work here or something to
Mm.
that effect. Do you deal with like concessions? I mean, are there cases where you would, for the service user, be able to get like a concession from a work point of view?
Yeah, well, in my years of experience, oftentimes because of a lack of understanding as or lack of insight into substance use disorders by employers, and because the people that are sorry. So oftentimes, so yeah, so basically what I mean is, what I'm trying to say is that oftentimes because service users are preoccupied with using the substances and the employer can't deal with the problems anymore, there's just everything just gets lost in translation, you know. So
Mm,
oftentimes, yeah, so oftentimes it's unlikely that you would find an employer who would go an extra mile to try and get this person into rehab. So oftentimes they just quit or they just don't come to work, then they just automatically get dismissed.
okay.
So yeah, so but yeah, that's something interesting I would like
Mm,
to see
yeah.
a lot.
Yeah, I've seen it like, with the educational psychologist. I mean, they do concessions. For instance, if a child can't write properly, they have a scribe and
Mm,
they obviously have to motivate for it. But obviously, I've worked for many, many years. So I do know the industry or how people function in that environment. And it
yeah.
is pretty intolerant, at the best of times.
But I think there was once a case whereby an individual was referred to for treatment, for an inpatient treatment, you know. Although the intentions of the employer was to get them to get help, and then after, if they relapse, then they are dismissed. We were able to sort of like intervene, you know, and try to ask for reasonable accommodation, to say, okay, we have this client, he has a substance use disorders, and upon treatment, upon assessment, we have discovered that they also have cognitive impairments and this and this and this and that. And now, in terms of work reintegration, this is what we would like for the employer to consider, so that this person can be able to perform optimally at work. So, but unfortunately, with that, you don't get a lot of support, you know. They
Mm,
can agree to certain things, and then they'll also say certain things can't be possible because this person has been in so much trouble, this and that, you know. So yeah, I think it also it just depends on the empathy, maybe from the employer side, and some understanding relating to substance use disorders.
yeah, I see that. And unfortunately, yeah, most of these employment contracts as well, they pretty, they have all of those terms like, you shouldn't do this and you shouldn't do that. And so the employee is obviously coming from, he's coming on the back foot in those cases.
Mhm.
So
Mm,
yeah, it's just interesting. Well, I just thought of it, and I just thought maybe there's instances where that does
mm,
happen. I haven't been personally involved, from a working environment, or
mm,
seen it, so I've got nothing to relate to. Um,
mm.
the other one
But
that
I think
came up,
I think
sorry.
it's yeah, and I'm just saying, I'm thinking, I think it's an important concept, because now that we are actually looking at substance use disorder as a medical condition, you know, with advocacy and awareness, eventually maybe we'll get to a point where the employer is more lenient towards clients with substance use disorders in terms of accommodations at work.
Yeah, and again, there's precedent. I mean, I just mentioned the educational psychologist, view, and I'm sure 20 years ago that obviously wasn't possible. I never came across the term concessions, but now it is. I mean, you can go to see an educational psychologist and get concessions. Even if it is like 15 minutes more on an exam. And I just think, if you add, like you use advocacy quite a lot in this conversation, but if we in that campaigning stage, I think there's definitely a space for talking about, okay, I mean, obviously we're not going to get there 100% now for this particular person, but is there any concessions that we can deal with or apply for, to be able to give him a better chance in terms of longer term health, for him. And I think
Yeah,
that would be quite a empathetic, approach to it.
definitely.
Depression and substance abuse, anything that you see that comes up very strongly with people? I mean, is depression linked to substance abuse at all?
Yeah, it's quite prevalent, hey. I would say where I currently work, it's an inpatient treatment, right?
Hmm.
I would say out of 10 of the patients that I would see, at least 6 of them would also have symptoms of depression, you know?
Yeah.
So it's quite prevalent, and yeah, the treatment becomes more complex because now you are dealing with a substance use disorder and another mental health. And oftentimes, one makes the other worse, depending on the substance that the individual used to use. For example, alcohol is a depressant itself. Although initially it may give people some euphoria just after intoxication, but the long-term effects are that of becoming depressed, low mood, and so forth. So quite often we find that individual service users who use alcohol also have depression as well. So I'm just talking about where I currently work, the kind of patients that I interact with. But yeah, and then some you find that after detoxification, they do have symptoms of depression. And because, as an occupational therapist, I can't diagnose, I will just highlight the symptoms and refer to a psychiatrist for further evaluation or psychologist. But yeah, so we do find a lot of times that it is quite prevalent. And
Okay.
it might also have been the reason why the individual started using substances to try and feel better, to try and improve their mood, to try and forget about certain things that they don't want to face.
Yeah.
So, yeah.
I must admit that always interested me because I never experienced alcohol like that, where it's a depressant, and so when people used to tell me that, it always, because when you see people at a bar or something, it's like the complete opposite of what I would see, what I would think in my head depression is about. But yeah, like you clearly said, long-term effects, and once it's worn off and stuff like that. But always. Yeah, always interesting. I started asking this a lot more in our episodes, but especially based on the time frames that or times we're living in. But substance abuse during the pandemic, did you see any changes in how how you dealt with patients, or how you started seeing patients? And it might be a weird question because obviously for a long part, like substances were banned even in South Africa. So, did you see anything around that?
Those were interesting times, hey. Um, Funny enough, people never stopped using substances, unfortunately. They always had ways of getting it, which is part of the criteria that they have some of the symptoms of substance use disorders. But what we saw during that time was that we because government was removing people from the streets and so forth. So we had a lot of referrals from shelters. you know.
Mm-hmm.
We had a lot of referrals from shelters because now people were experiencing withdrawal symptoms because they could not get the substance anymore from the streets and wherever they were. So yeah, so there was a high rate of referrals, a high rate of withdrawal symptoms, you know, and we had to speed up admission. So I think during that time, we had the highest admission rate than usual. And yeah, and I also think the treatment that the treatment seeking behavior was not that of I'm tired of substances. I can see that they're having an impact on in my life. It was more of I have no choice. I want to get rid of these withdrawal symptoms.
Mm.
And if there's a center that has a detoxification unit where I can get medication to make them feel better, I will go. So oftentimes we see that when after we admit them, 3 weeks down the line, they want to leave. And, you know, just like with hospitals, we have a policy of hospital refusal. You know, if a client wants to leave and they refuse treatment, then we let them go. So, yeah. So during that time, we had high rates of admissions and also high rates of well, no one called them abscondment, but it was more of I want to go. I can't ready anymore. I want to go. Yeah, so yeah, those
Mm.
were quite interesting times, you know, and it showed us that we have a problem. We actually have a substance problem. South Africa has a substance problem. And we need to do a lot of awareness, a lot of prevention campaigns, you know, because oftentimes people take substances, but they don't know the consequences thereof.
Mm.
They only discover when there's relationship issues, family issues, you know, school work, when it starts affecting their relationships or participation in community engagements, then that's when they start seeing that things have spiraled out of control.
Yeah.
So we also try to educate on know what you are taking, especially with the teens, you know, they
Mm.
just take substances and only realize at a later stage that it had certain consequences.
Yeah. And I think when you're in that zone, that's what Tando Pato, the author, mentioned earlier. She spoke about was only when she decided to become clean, did she start seeing how some of those relationships, worked. And I think she mentioned, like work relationships, personal relationships, because, when you're in that zone, you're not seeing things clearly. And I think only once you take a step back and you don't have that substance abuse, that you can kind of see through that. And I just wonder, like, even as a society, I mean, South Africa has so many problems, but, I wonder how much of that is related to, like, just the way as a society we deal with substance and, substance abuse and stuff around that, because you don't
Hmm.
see clearly through that,
Definitely, and more because you know, like I mentioned, substance use disorders affect the brain, and you know, certain damage to the brain cannot be reversed. Some damages are irreversible, and the only way to try and help these individuals is to try to come up with methods of compensation. You know.
Mm.
Mm.
Cool. Thanks, Joanna. This has been amazing. I've got two more questions and then we're going to wrap up. I can't believe it's like going on an hour now, but I mean, it's been an amazing conversation for me. And yeah, you definitely brought your A game with it. But I want to ask, is there any other interventions from an occupational therapy perspective that you normally help people with that we didn't cover so far?
Oh yeah, yeah. So some of the interventions we do is to facilitate interpersonal skills. That is, we do a lot of group sessions to provide a safe environment where service users can learn all these skills, because oftentimes, because of substance use, they've sort of like lost all these interpersonal skills that are needed to maintain relationships. We also aid in leisure exploration, participation, that an individual can participate in the absence of substances. So we also do planning and initiating of and initiating and evaluating short and long-term goals that enables participation in activities. We also work with clients and families to identify occupations and activities that are important for personal, family, and work life, just to have that balance, you know. And then oftentimes we find that there's issues with financial management. So, and that forms part of what we call instrumental activities of daily living, which complements the basic activities of daily living. That is, so we do, we will facilitate money managing strategies as well. And then also just learning new coping skills to replace the maladaptive pattern of substance abuse. So yeah, I mean, I think because with substances, we also look into, research has now come about to say that motivational interviewing helps to try and move a client with substance use disorder to more of an action stage of wanting to get treatment. As much as it is more of a social work or psychological treatment, we have also tapped into the treatment of motivational interviewing, you know. So, and that helps a lot, especially because motivational interviewing is more empathetic, it's understanding, you know. You're not trying to convince the client to change. You facilitate that change in them. So you just ask questions in a more strategic way for them to try and reflect and make an informed decision about their use of substances, you know. So that at the end of the day, if you have someone who is on a stage of pre-contemplation, they can eventually move to contemplation, where they feel, oh, well, if they did not see that substances had any impact in their lives, then now they can see, they can evaluate and say, oh, but I can see it's having an impact on my relationship, or it's affecting my work, you know. So we use motivational interviewing as well as part of treatment.
Okay, that's amazing. I mean, you mentioned some really cool ones there. Just to tap onto that, I mean, and if you don't have it on hand, I mean, that's perfect as well. Is there any resources that kind of spring to mind for you? I mean, it could be websites or books or anything that you see that you normally point your clients to.
Oh yeah, So usually there isn't a lot of support groups, you know. So, but we just know of the AA or the narcotics. So what we're trying to do in this instance, especially where I work, we've come up with programs, you know, leisure programs that we can enroll individuals with substance use disorders to continue with post-discharge. And then in terms of websites, for individuals who maybe think that they have a problem with substance use disorders, there are screening tools that they can find online. One that I know is called the Assist. So it's just Assist with capital letters. It's like a self questionnaire, you know, just to try and answer and just to determine your use of, how severe your use of substance is. And yeah, I think also there's still a lot of work to be done in terms of resources for substance use disorders, because even I myself, when I look on the internet and I tried to point my clients in that direction, it's always a challenge. So as part of occupational therapy, adaptation is one of our best abilities. So I just try to come up with my own programs, own activities that can try and assist the patient with treatment of substance use disorders, you know.
Yeah, that's amazing. Yeah, I think you're right. I mean, I think we came across it like when we were talking about career counseling the one time, and even the psychologists at that point were saying, they learn some stuff all the time, but they're always scouring, for those resources. And but if you come across any, and we can add that to the show notes, that'll be amazing. We'll obviously have your details as well in the show notes, so people can contact you if they need to. And then I think we can wrap up, but I just want to ask, because we're trying to do our best in terms of, understanding the topic and asking the right questions, but is there anything that you thought I should have asked you that we didn't?
No, I think we covered everything, even even a bit beyond some of the things. But yeah, let me see. Yeah, I think we've covered. I think we've covered everything. Yeah, no, there isn't anything from my side.
Okay, that's amazing then. Thank you very much for your time. It was an absolute pleasure to have you on the show, Johanna.
Thank you for inviting me once more.
Hey everyone, thanks for listening. As always, stay tuned and we'll speak to you in the next episode.